Hello, I'm Emily Binstadt. I'm an emergency physician at Regents Hospital in St. Paul, Minnesota, and at the University of Minnesota. Welcome to our talk today about experts as learners and multi-center approaches to simulation-based faculty development.
And I'm Sarah Hawk. I am an emergency medicine physician at Rush in Chicago, and I'm also the director of emergency medicine simulation at Rush. We're excited to be here today. We have no disclosures.
So our learning objectives for today are to identify barriers to teaching and assessing procedural skills when we have experts as our learners and when we're using simulation-based technologies to do that teaching. We also want to discuss how to identify what are the procedures that you'd like to teach, how to guide your expert learners, and how to introduce the concept of assessment to that group of people. And lastly, we'd like to help you develop future directions for courses in procedural skill development, particularly for practicing clinicians and attending physicians. So we'd like to have you start off by thinking about the topics or procedures that you want to teach. And every institution is different. Every individual educator is different. Your priorities, your goals, and even just the time we're living in. Certainly there are things in 2020 that are different than the realities we were living in earlier. And so different things are going to come to the forefront, and hopefully this will let you reflect as we go through this. Normally we would present this material in more of a workshop environment and give you some time to talk with your colleagues who are also attending about this, but in this format, maybe just taking a moment to jot down a few ideas that are relevant to you will help you clarify what your goals are and how you can get most out of this experience.
And we also kind of came up with a couple of ideas of things that might be possible topics for you to consider. I've included a photo here of earlier this year practicing a different type of intubation protection system in the kind of the beginning of the COVID era. And that is something that might be on your list at this point, trying to keep your team safe. The other things that you might consider are some low frequency procedures like cryothyroidotomy, thoracostomy, or central lines. Sometimes, high volume trauma centers, the chest tubes and the lines are not as high yield, but depending on your practice environment, that might be something that your team hasn't done for a while, especially if there are residents doing a lot of procedures, and the role of the faculty is to oversee them. So there's a lot of different settings that all of us work in and practice in. And so depending on your setting, you may have different needs.
And we've even gotten, as Sarah was saying, our definition of procedures has evolved a bit. Initially, very much hands-on, defined skills, and has evolved a bit to recently we've done things like topics on microaggressions or even giving feedback and called those procedures. So.
Right. And, at Rush, we've done some high fidelity simulation in teams of physicians all working together, board certified EM physicians, and then all of a sudden we're throwing them into a simulation. Many of them haven't trained under these circumstances, and so they never knew how to react in a simulated environment, but we've found some really great success with that. So anything that you can imagine with simulation that you think would be valuable for your learners, our feedback has been really, globally quite positive.
So I think that's the goal of this talk, is to kind of give you a roadmap, no matter what it is specifically that you're thinking of doing, a roadmap for at least with experience of two centers, what things we have in common, what things we differ on as far as our historical efforts to put these programs together, and hopefully you can take away some pearls that would apply to your situation.
So I'll take a moment to review for you some of the background and some of the literature to take a look at as you're thinking about building your curriculum. There are a lot of checklists and studies looking at learners, medical student learners, resident learners, a number of different backgrounds there, specifically looking at early simulated procedural exposure to see if that translates to future success. The principles of deliberate practice and mastery learning by Barczyk and McGahey are very critical background pieces to be aware of and to think about incorporating into your simulated program. There are also some validated checklists for procedural instruction and assessment of both central line, lumbar puncture. Some of those were done by different experts determining which steps on the checklist were critical. And all of those are good background to know about as you consider how to move forward with your procedural instruction program. As we know, there are trainee requirements for physicians graduating from residency, specifically in emergency medicine. We need to log 17 distinct emergent procedures, in some of them quite high numbers. General surgery has to log 850 major cases, and there's a number of different case types within that. Anesthesiology has 10 distinct patient groups, and each of those require 20 to 40 cases. So residents are absolutely logging their cases, but following graduation, there's very little repetition or purposeful practice of some of the less common procedures. And if we don't encounter them in our clinical practice, first of all, the confidence level, but also potentially the competence level can decay over time. And that's one of the main arguments for repeating and practicing these procedures, even if you feel very confident that you might be able to complete it correctly. There are also specialty requirements for board certification or for board renewal. Within the general surgery specialty, the fundamentals of endoscopic surgery is a simulated program that is required. The anesthesia OSCE since 2018 is something that's been required for board certification. And then within anesthesiology, the maintenance of certification in anesthesia is one simulated program that is possible to include in your recertification process, is my understanding, for the anesthesia board. In addition, there are a number of simulation-based continuing medical education opportunities for practicing clinicians, and these seem to grow on a regular basis. They're rather high resource and high intensity programs to run for the centers that run them. Being able to offer this in your own institution, if you have the simulation background and the simulation expertise, can really be a great contribution that you could make to the institution. Some of the papers looking at this do note that simulation-based CME increases clinician confidence, and also that after multiple procedural attempts, such as nephrology fellows, they did score better on dialysis catheter insertion with repeated attempts. And that was more of a mastery learning in people that would be generally considered experts, nephrology fellows, who have done quite a number of these. There's always the possibility to take a look at that type of confidence increase or some other measure of how experts respond to these training sessions as well. Another thing to consider is that the Joint Commission does require an ongoing professional practice evaluation of faculty members that are practicing, and that's documented twice yearly by the department chair. Usually this is something where the department chair takes a look at your outcomes, maybe reviews charts, maybe looks at a procedure list of your documented procedures, or checks to make sure you haven't had complications. But within emergency medicine, at least, this is not generally something that is completed on a procedural case basis. But of course, all of these things must be considered. And so including procedural skills and procedural ongoing practice and evidence of that in an OPPE program could be a real boon for the institution as well. There are not a lot of published techniques for OPPE, but this is one of the things that it could be used for procedural studies in experts. So for example, there's an online format in psychiatry that has been used, and then a chart review of key documentation in anesthesiology. There's a couple of studies that have looked at this in the past. But we really do need a way to evaluate experts. And in one study, there was a checklist that had previously been designed for trainees, and Barsic looked at adherence to that checklist, which is one way to consider evaluating your expert learners. But a lot of the procedures that are completed by these specialties that we've been discussing don't have consensus procedural checklists. And there's no one way to perform a procedure, especially when you get into a procedure that has many steps. There are many safe ways to get to that end. So considering what the best way is to evaluate these experts that may have adapted different ways of achieving the procedural success over the years that they've been in practice. In addition, sometimes hospital administrations will request recredentialing data or kind of try to get a sense of physicians performing procedures and how often those have happened. So that type of thing, a practice procedure could be documented as part of that, that shows a physician has performed a procedure that the hospital is interested in. And the final thing that I'll say about kind of evaluating experts is that attempted subjective evaluations of experts may be biased by the apparent age of the expert that's being evaluated, by the apparent experience of the expert being evaluated. And so those types of bias are very difficult to try and tease out in a way that could be meaningful, as many different institutions may consider trying to evaluate experts on their procedural skill as simulation becomes so significantly more widespread.
So, I think as Sarah and I have tried to work in this arena, as she discussed, it's an area that's got tons of possibility. It's exciting to work on, and there's definitely an intrinsic appeal to it, but it isn't something that if you flip through a simulation journal or talk to your colleagues, that you'll notice a ton of people are doing a lot of work relative to the work that's being done in maybe resident, med student, nursing populations. And so why is it difficult to do simulation-based expert training? We've identified 3 distinct areas that we think are the things that create these barriers. So actually they're kind of all represented even in just the title of this presentation, but the fact that they're expert learners, the fact that it's simulation-based, and that we're focusing on procedures that are rarely performed. And each of those areas has its own nuances or barriers that make doing this type of work more challenging. And then when you combine them all together, you can get overwhelmed sometimes by all the barriers. So in order to break this down a bit, we'll talk about these in detail. So we normally, if you were in a group of your colleagues, we'd have you discuss this, but for this talk, maybe think about 3 barriers that as you've entertained doing work in this area, you've experienced. And even as you're kind of brainstorming about those, think about which category of these 3 that are highlighted in different colors your barrier falls under. For instance, if it's a barrier related to teaching via simulation, is it a barrier that it's based on, your learners are experts, or is it the procedural nature of the thing you're trying to teach being rare that makes it more difficult? So to discuss those areas a bit more, hopefully you've had a chance, I stalled long enough that you've had a chance to think of your own issues, but just going through some things that have come up regarding simulation specifically. Small group training in our program we have for our faculty training, we have only 4 people participating at a time. Sometimes when you're trying to assess people, your goal is even to do one-on-one training sessions. So that just gets very repetitious for the person that's doing the training. Clinicians also, as Sarah mentioned, may have very limited experience with simulation due to the time they trained. And relative to that, and sometimes, directly as a relation to their comfort level, their buy-in for simulation is also similarly limited.
And if I can add to that, Ellie, just to kind of think through that a little bit, one of your responsibilities as their peer educator, so to speak, would be to acknowledge that and say, some of us might not have trained with simulation as part of our training program. And this is part of your pre-brief. This is how you get your learners engaged. You say, I'm going to do my best to make a situation that will help you at the end of this practice something and feel better about your skills, and hopefully even improve and maintain your skills. So if you pre-brief this correctly, even those, senior partners and folks that have been out for a long time and may seem set in their ways might say, oh, you know what? Thanks a lot for doing this. I feel like I learned something.
That's a really good point, Sarah. I think also that, sometimes buy-in and experience, the reason we're going through these barriers is to then be able to isolate, okay, which barrier is this? Not just throw up your hands and say, this isn't working. Nobody's participating. People aren't buying in, even though I'm putting all this work into it. And so being able to kind of isolate, okay, where is this problem exactly? Then leads you to be able to do exactly what you're discussing is, head those things off before you even get into the meat of the thing. Because your problem may not be with your procedure. It may be that people have fear of simulation. And so addressing that fear straight up right off before you even get to what you're trying to teach can make you more successful. Mm-hmm. So lastly, regarding barriers to simulation, realism of the procedure, that's always something that we're talking about in simulation, suspending disbelief. And sometimes, especially folks that haven't done a lot with simulation or may have fear of performing in simulation-based environments, but have had more experience in maybe a cadaver lab or an animal lab, they may be comparing constantly to like, oh, well, this isn't as realistic as this that I think is better. So sometimes acknowledging that and what the pros and cons are and why we're doing this is useful.
And the photo there, just to be clear for a second, the photo in that bottom right corner, isn't that a thoracotomy?
Yes. So this is our, we did a emergency C-section lab with our faculty, and in order to have enough, we do have a full-size high fidelity mannequin that's a birthing mannequin, or a couple of them, but we just didn't have enough time to reset the mannequin between each rotation of our faculty. So we created these bins basically filled with various things you had to cut through. It was a very, very low fidelity, but did the job situation. So yes, that's our mannequin head taped to the top of the table. So sometimes the fidelity is only as high as it needs to be to get the teaching accomplished. And as long as everyone's sort of able to acknowledge that, they can move on. So, yeah. So the next area of barriers is talking about expert learners. And I think that's something that when you're used to teaching residents or, early in their training or early in their career learners, it's easy to get used to being like, oh, this is when they show up, and they all actually show up and someone takes attendance. And if they're not there, there are repercussions. And, none of that applies with faculty learners as much. But there are some things you can do to address the differences. So first of all, in emergency medicine, which Sarah and I both practice, there are time constraints. So people have round-the-clock staffing that we have to maintain for sometimes multiple emergency departments. And so scheduling is a big deal. If you want to get your faculty to show up, you have to be organized and you have to do these things in advance, and you have to get your time frame out before the schedule requests go in, or you're going to be chasing your tail, running around trying to get people to show up for something that you're putting time and energy into. So be organized and do it far enough in advance so that you can address that. There's also just clinician willingness to participate. And I think I alluded to that earlier, but sometimes attending physicians in practice or faculty physicians are not as cajolable as people in their training timeframes are. So sometimes they need to be incentivized either with carrots or sticks to participate. Performance anxiety in a group setting of your peers is a real thing. We are not put in that position very often. I mean, usually, you know, even if you're working in a multi-center or multi-coverage ED, you're not working directly side by side with your colleague at your level. There's a different area of the department that you're sort of operating independently as, you know, heads of the ship or whatever. And so people don't really have to perform. Often these are also because they are procedures that they're not doing every day. There is some concern that they may not perform well. And so that's a real thing. There is also, as Sarah mentioned, disagreement on what the procedural technique is that's best. And ultimately, you know, we can create a checklist. As soon as we've done that, though, our faculty will disagree with, you know, B4 or whatever it is, or, you know, item 5A. I think that's a bunch of crap. I don't think that's, you know, something that I have to do. I've done 12 of these in the last month, and, you know, I didn't do it once. What do you say to that? You know, so they can get kind of less willing to participate in your learning if you're either unable to say that your checklist has been validated in their population, which likelihood is it hasn't, or if you're willing to, or if you're not willing to allow them some input on what the assessment modality is that is being used. And so I think we'll talk more about this, but I think sometimes when you run into that, you have to acknowledge that there is expertise that you're gathering in the room. And sometimes, you know, getting that feedback and trying to refine your teaching and making it better is the best way to address that. There's also definitely the issue of hierarchy. Specifically, often people who are doing simulation may have done a simulation fellowship in their first year out as an attending, and here they are talking and trying to teach someone who's been in practice for 30 years. And that, you know, interaction can in and of itself be stressful. Often it goes really well, honestly, but sometimes it doesn't. And so being able to sort of pinpoint that might be the barrier or the problem is good to think about. And then I think lastly, just this point about whenever you bring up these words, competence, remediation, credentialing, certification, and retention, those are buzzwords that make people's, you know, fear and anxiety levels go up. So if you're going there, just know that you are going to a place that makes people worried. And so do it with your eyes wide open. Yes. Make sure you really want it and need to do that. And then lastly, the barriers to teaching rare procedures. So often we don't have trainers for these. These are not commercially available things. Companies aren't going to make a ton of money selling a specific trainer for a procedure that's very rarely performed. So you may have to make your own trainer. Also, the issue of validating that your training or your checklist works either in the clinical environment or the simulated environment is really challenging if your procedure only occurs twice in a year in your emergency department and you're teaching, you know, 60 staff. The likelihood of you being able to tell if there's a difference between someone who's trained during your simulation setting or not is almost none in that setting. So you have to be creative about how to do your translational research. Mm-hmm. Additionally, by definition, rare procedures vary by clinician. You know, we can have people who've been in practice for 20 years and never seen this particular thing in their actual day-to-day practice, and someone who's in their first year who's seen 3, and it's just luck of the draw and chance, and it can work out that way sometimes. So experience doesn't always correlate with years in practice. And then lastly, with some of these things, especially people that are tasked in simulation with teaching these rare procedures, often we may not, as the instructors, actually have firsthand clinical experience. So we may need to call in other experts to co-teach with us or do extensive training to be able to teach it. Mm-hmm. So those are kind of a list of the barriers. And the reason to go through those isn't to discourage you, because there are a lot of barriers. It's to help you isolate where your problem is and be able to more, address them in a more refined, more effective way and make your program a success. So again, we'll let you take a minute to reflect on where your program is and what your barriers are to implementation. And the more you can kind of categorize them, I think then you'll be able to kind of highlight, as we discuss some of the solutions to some of those, maybe get some creative ideas for yourself moving forward. And I guess in an effort to help you do that, Sarah and I would like to just review the programs that we've developed over the last several years at Regents Hospital and at Rush. I'll start. So again, our program has been going on since 2008. As a group of us was interested in simulation, and we basically said, well, yeah, it'd be cool to do some of this stuff with faculty. We're doing a lot of work with med students and residents. We approached our department chair and basically said we wanted this to be mandatory because we were worried that otherwise our faculty would not choose to participate. And fortunately, our department chair said, okay, sounds like a good idea. And that's how our program began. Because we were initiating it with a mandatory situation, we were very worried that we would have backlash, especially if we tried to tell our colleagues that we were assessing them in any way. So we very, very purposefully avoided any sort of assessment in the first several years of our program. And it was all very collegial. You know, there are no bad questions. You are the experts. We want to learn from you, but this is a chance for us to get some hands-on practice. We recognized that people were missing out on opportunities to do procedures because they were always being, we work in a residency training program, and the residents were always getting first dibs on the procedures, which is great. That's how it should be. But faculty who didn't work in any other community setting were going years without actually doing an intubation or actually doing a central line or some of these things. Eventually, over the years, we did include some checklist evaluations that were peer filled out, and then we surveyed them to see how that was perceived. And it turned out that they were actually looking for that by that time. But I think in our setting, at least, it was important to ramp up to that to gain confidence and gain that sense of acceptance or quell any fears of being judged before we introduced the assessment piece. We do arrange for CME. At one point, it was important to get specific pediatrics or trauma CME, and we did arrange for that to happen, which was a bit of the carrot that we were discussing before. And then at times, we've definitely included specialists. So we've done some neonatal resuscitations, and we've had neonatal nurse practitioners there. We've had trach troubleshooting, like clogged trachs or displaced trachs, and we've had respiratory therapists come co-teach with us for those settings. Some of the OB emergencies that we've taught, we've had OB folks come in. Those are things just off the top of my head, but sometimes it can make a big difference to not pretend that you know what you're talking about as the emergency physician and to have that additional expertise. We have found, however, that when there is someone from an outside department present, it often helps to have it co-taught with someone in emergency medicine so that it's like the areas where the emergency physicians really need to learn can be highlighted by the person in emergency medicine, and things don't go off on a tangent some other direction. So the way we've structured our course is that we have approximately usually between 2 and 4 sessions a year. Each session has 4 stations, and up to 4 experts or faculty members can be in each station. We just rotate through them, and we do that annually. So I will let Sarah give an explanation of her program, and then I got to go plug in my computer because it's dying. I'll be right back.
So while she's doing that, I'll tell you about the rare procedures here at Rush. So our program was actually initiated by our department chair in 2015 as a way to augment the OPPE by giving our faculty an opportunity to perform a number of procedures. So participation was mandated immediately by the chair, given that that was one of the requests that he was making to our faculty to participate. We had actual immediate adoption of suggested or published checklists for all of the procedures. And as at the time a sim fellow, I jumped in with a lot of gusto to initiate these. And in retrospect, it was probably a lot. So I would endorse Emily's approach to either limiting checklists or providing them as guides, which is what I do on a yearly basis now, where I curate a checklist and offer it as a guide to remind faculty, especially procedures that they're unfamiliar with, having not done recently, just to say, yes, this is the guide that I'll use to go through this procedure and practice it here. We did also give CME, it's a, as Emily mentioned, it's a pretty big carrot. And it helps soften the blow of it being required. And it also, it truly is continuing medical education to practice the procedure. So it's very reasonable to seek and supply CME for this type of an experience. We do a similar number of sessions, and we typically do faculty peer educators, and those folks seek out guidance from people outside of emergency medicine. Just because of the number of sessions, it's a little bit challenging at our institution to get other specialists to come and attend as many of those sessions as we do hold. So we've had them serve as content experts, especially at how things are practiced at our institution, and they kind of guide the specific content that we're providing, and then it's primarily an emergency physician doing the peer proctoring. So this is a very busy chart, but just to see kind of what types of procedures have been done at both Regents and Rush over the past now many years. And you can see, in general, we vary the procedures from year to year, but also do maintain many of the same from year to year as well to make sure that we're getting adequate practice, and especially for some of the most rare, that we just do it on a regular basis.
And there's really not great data about how often you have to repeat some of these things. And the answer probably is more often than either of our programs are doing. But if someone wants to publish something about that, that'd be great. Go for it. We've come down on, we have sort of the bandwidth and capability to do our lab annually. And so we've started doing 2 repetitions and 2 new things. And eventually, maybe we'll run out of new things to offer and we'll repeat more of them, but it seems that our faculty keep coming up with, oh, you do this idea. So we try to keep it fresh and split it about half and half with new versus repeated content.
Yep. And our including high fidelity simulation has added another dimension as well at Rush, just having the chance to provide some pretty critical patients and practice together on how they might be managed has been useful. So a lot of variety and a lot of options depending on your specific sim center's capabilities. So. So overall, we did have, when we compared experiences, starting a couple years ago, we noted that, in our similarities are primarily that the participation was mandated by the chair, that we're offering CME, that we do seek input from other specialties on procedures relevant to their expertise. And overall, our goals are to improve procedural skills, to improve accountability within the department that everybody has participated, and to increase faculty confidence in these procedures. We already mentioned some of the differences, so I won't go through them in detail. But overall, trying to make sure that we're gaining the buy-in the best way possible, and considering that gradual introduction of the checklist or introducing it as a guide.
And I think, Sarah, you also, when you first started, you were able to offer them the chance to be able to do some procedures that they hadn't been able to, as if they had been credentialed basically via your training, right? So that was another kind of carrot in a way. You wouldn't be able to do this procedure in the emergency department unless you had completed the training.
Yeah, and I'll get to that in a little, actually, right now. So I'll use as an example for us that at Rush, one of the requests that has come from the medical staff office is to have everyone that performs conscious sedation do an hour sim session related to conscious sedation complications, and preparing and being prepared to handle those. So that is something that I was asked to incorporate into the simulation program, and did so. So we got all of our faculty through that program. And I also wrote that program for the other specialties within the hospital, with cases relevant to what they do on a regular basis within their specialty, what they're sedating for. So that is certainly a carrot, I would say. And there have been a couple of bumps with that, but overall, I think it's a good program, and for hospitals considering that type of kind of involvement of simulation, could be a really positive experience for physicians practicing.
I guess just as another example, I think we alluded to this once before, but we did do microaggressions just last year, which turned out to be timely given what 2020 has shown us. But basically gave faculty a chance to respond to microaggressions and then discussed afterwards how that went. There's no, I think the point of that, mentioning that program, is that there's really not any limit on what you define as a procedure. It can be whatever you think is relevant and interesting and important for your faculty to practice or learn about. So that's just to kind of give you an example of something that might not be front and center on your list.
So moving on, we know that many of you watching might have done some of this already, and might be the leaders of programs at your own institutions. We're very interested in finding out how your programs have gone, and how those might have been laid out. So we actually have an ongoing survey of simulation for attendings, either attendings in practice or faculty, and faculty development programs related to simulation. So if you are a leader of one of those programs, we would very much like your participation in a survey. We're collaborating with the two of us, as well as Susie Bentley at Elmhurst in New York City. So please reach out if you have experiences like this, and let us know so that we can include your perspective in this survey.
And as we talked about, sometimes this, the same reasons that the barriers exist for this, there's also another set of barriers. Some of them are the same and some are additional to publication of these works. So we would just like to know and document what's going on with this group of learners in this setting. And so that's the goal of this survey, is to get the news out that this work is actually happening. and how it's happening, and we'd like to know more.
So if you haven't already, we would encourage you to consider creating your own experts as learners situation, scenario, procedural training workshop of a rare procedure of any definition for your own group of expert learners, whether that's within nursing or physician assistants or nurse practitioners or physicians, whatever your group is, the expertise of those practicing within your specialty. There are a lot of different things that we have to do on a regular basis, specifically with procedures. And so kind of take a minute and think about what you might consider for a procedure for your group. What learner group are you targeting? What are the goals? Why would you want this learner group to complete this procedure? And how good are they going to be? Are you just checking that they can all do it? Are you providing additional training to make sure everyone has had recent training? Or are you doing kind of a touch base to make sure that a relatively common procedure is being done well? How are you going to obtain buy-in? And what kind of administrative support do you need? So we'll go through a number of the things that you might need from your manager in this type of a situation to make this program successful for you.
And this is like the best question ever, right? Like if you actually get to the point where whomever you're asking this to says, okay, I'm in, you've convinced me. I think your program is a great idea. It's needed. We're on board. What do you need from me? You don't want to be like, I don't know. You want to have your list of what you need. So hopefully this will help you get those things on that agenda so that when you get to that question, you'll have good answers.
So the first thing that we have as recommendations are just the logistics. And some of this is institutionally, and so it's hard to know what each institution has. But if you aren't in a position where you already know this, finding this information out is really relevant. Do you have task trainers? Is there someone that you can get expired kits, central line kits, chest tube kits, some of the things that you might need to practice these procedures?
And sometimes I would just say for that, sometimes the things that are available in our sim center that someone has procured 10 years ago, and we've been using, rarely because it's a rare procedure. The kit that's stored and repackaged every time in the sim center may not actually be the same kit that's being used in the clinical setting any longer. So it's worth checking.
Right. And the investment involved with opening a brand new kit makes those expired kits the most attractive, but you can really justify in a lot of situations opening a new kit after discussion with your team if that's something that you really need to make sure your faculty are familiar with, because being familiar with the procedure and how to do it and having the possibility of down the road saving a life by doing this procedure correctly, that is in general, from my perspective, worth opening that new kit if that's all you can find. So really think about where you're getting it from if you can, to conserve resources, but if you can't, think about a new one. Also, multiple replacement parts. So if you're doing a cricothyroidotomy, you might need that skin over the neck of your trainer, and seeing if your sim center has a way of reproducing a large number of skins, or if you happen to know that. Some of those methods are also here at IMSH in different scenarios. So if you don't know how to make that type of stuff and you want to, it's probably something you can find out from the schedule.
And if you're not making it yourself, it's just those disposable parts of whatever it is that you're going to be creating are usually the things that get used up, and that's where your cost is going to be, aside from any costs of using the center or the equipment that's more durable. You have to figure out who's going to be paying for those replaceable parts component.
Yeah. And of course, simulation mannequins, if those are what you're using, checklists like we had talked about. And then specifically who's going to be teaching and which of your colleagues might be interested in this type of peer educator role. So
I think I'd just commenting on that one a little bit more, as we've done this over the last almost 10 years now or more, you know, initially there was a group of people that were very interested in teaching. And so that group of people, that's probably how we got to 4 sessions to begin with, probably because I had 4 people that were interested in teaching simulation simultaneously and letting people rotate through. You know, as time has gone on, people's interests have diverged and their availability has diverged. And so, you know, trying to recruit the next generation or just a cadre of people that's interested and willing to put the time in to do repetitive teaching on these topics is the next challenge for our institution. I I have to share this success story. I recruited someone to help me do Crike last year, and he had never done it before. And he texted me probably 2 months ago, middle of the day, and said, "Emily, I'm so glad we did that Crike station. I seriously think this guy is alive because of it." He had a really difficult Crike, and he just felt like he could obviously teach the resident better, and came up with some techniques that, you know, whatever, that felt good. So I have to share my success story there.
Absolutely. Going through a little bit more of recommended resources so we can finish on time for you. From the perspective of administrative support, the mandated participation that we both benefited from really helped. The dedicated time for us as facilitators and potentially for additional facilitators if possible, and then funding for simulation time and supplies was all really critical for me.
And we do not have mandated participation anymore. And I'm not actually sure exactly where that became less clear. We didn't announce, oh, you no longer have to come, but it's not mandated per se anymore. Although I think we get to this later, we are including it as part of our qualifications for getting our bonus, which does mandate certain activities. This is one of them. So.
Mm-hmm. Yeah. And so, you know, speaking to learner buy-in, having continuing education is a really big way to make sure that they feel like their time is valuable during that. The input from specialists can be really helpful as well. You can ask those really nitpicky questions of a specialist that you might not feel like your peer might know the answer to. And the availability of the trainer for a rare procedure can really help encourage people to come, because it's not every day that you get it set up for them and you have the supplies for them and you have all of the details and the checklist and all of the organization around providing an opportunity for them to do that procedure. Advance notice is key, like multiple months of advance notice, especially if you as the facilitator want to do a limited number of sessions and not be doing makeup sessions all the time. And then whether for your learner group it's overtime or bonus or incentive structure, some sort of inclusion in that can be helpful as well.
And I think, though, that the biggest thing for the learn incentive is making your the time spent there being a high yield experience. If they feel like they're getting something out of it, they're going to be back the next year.
Yeah. All right. So as you're creating your own, think about your ideal for you, how you're going to get your learner buy-in, what goal you'll share with your learners, and what you might need from administrative support. So as you're thinking about this going forward, how that might be helpful for you. And as part of what we would do in person, and I think could still be helpful for you, if you're thinking of one rare procedure that would be appropriate for this group that you've just focused on, why that procedure? Do you need to make a task trainer? Do you need to buy one? And how would you measure success on that procedure? Who might you need in your institution to tap for expert input? And would you have them in person, or would you have them train the facilitator, kind of a train the trainer on the procedure? So thinking of the different logistics could be helpful. So a couple of resources for you as we wrap up here. There's a number of different studies that might be useful to look at, assessment tools and scores, behavioral checklists, error-based checklists, a couple of different things that you could look at. And then some consensus statements and ways of kind of defining professional competency might be a helpful thing to look at. Skill retention in surgeons. If you have recently done a bunch of the same procedure, you may make fewer errors or mistakes. And then thinking about how to leverage an intensive surgical education program or something similar in your own environment, and if that's something that might be relevant for your learners or much too much of an investment. So just looking at a couple of different things. We can provide these links if you email us, which is, I believe, on the next slide. So you can take a look at ways to get in touch with us. But overall, to kind of recap what we've talked about, there is relatively limited literature on expert procedural skill assessment. And it's an opportunity for growth, but it's an opportunity to really also make sure that experts continue getting procedural skill training and keep our patients safe as our ultimate goal. There are some barriers to implementing courses like this, and we talked extensively about those, but there are also ways to anticipate those barriers and with the right resources to overcome them.
And I think that Sarah and I are also open to any discussion about those. Like if you have a program that you're trying to start, we've been doing this for a while and we've sort of thought about these things, and you want to reach out and give us a specific example, I think both of us are willing and open to kind of talk you through that a little bit more too.
So as we've demonstrated, you can absolutely keep these courses going over the course of many years. And I mean, again, the reason that we do it is that simulation provides a unique environment that facilitates this learning and this practice. And it's why not give the experts the opportunity to practice if their patients may have a better outcome, like in the case of the Craig story you shared. That's the reason that we do it, at least the reason that I do it. So I think there's a lot in future directions for this area. And if you do have questions, I'm including our information here. So please feel free to reach out, share your experiences, share your challenges. We'd be happy to chat with you about it. And in addition, this is also if you want to complete the survey, that would be where to reach out to us. Okay. So thank you so much for watching our presentation. And I think we'll wrap up there. All right.
Have a good day.
Have a good one.